Wake up, cat. Wake up, cat. Wake up, cat. Seriously, cat, I'm tired of you falling asleep in my lectures all the time. I haven't even begun yet. Please pay attention or leave now.
I'm so sorry it won't happen again.
Okay then, well let's begin. Today we're going to be covering a topic likely relevant to you, cat, narcolepsy. Narcolepsy is a chronic brain disorder that is classified within the category of excessive daytime sleepiness, or EDS. Narcolepsy is a form of hypersomnia, in which someone who suffers from the condition can fall asleep very easily. Narcolepsy affects males and females equally, and has been shown to affect 25 to 50 per 100,000 in Western countries.
Wake up, cat! Wake up, cat! Wake up, cat! Wake up, cat! Why is she sleeping? Wake up, cat! Something's wrong with you. Wake up, cat! She has narcolepsy. Wake up, cat! What should we do? Wake up, cat! Why is she sleeping? Wake up, cat! We have tablets for you. Wake up, cat! She has narcolepsy. Wake up, cat! The teacher's mad at you.
Cat, wake up! I've had enough. Get out now!
In a normal sleeping brain, there is a stable balance between wake-causing, sleep-causing, and wakeful-stabilizing neurotransmitters. The primary sleep-causing neurotransmitter is GABA, produced in the basal forebrain. GABA acts to inhibit cortical control, which is reflected in reduced brainstem activity and movement during sleep. GABA also directly inhibits orexin production from the hypothalamic peptidergic neurons and indirectly inhibits the wake-causing neurotransmitters such as serotonin, acetylcholine, norepinephrine, histamine, and dopamine. In the normal awake brain, higher concentrations of orexin A and B are produced exclusively in the lateral hypothalamus, and these act on OX1R and OX2R receptors at the respective sites of wake-causing transmitter synthesis. These transmitters likewise inhibit GABA production, maintaining a state of alertness as well as many unrelated functions associated with wake actives, including mood and appetite. Serotonin and norepinephrine are especially multifunctional, inhibiting REM sleep specifically and maintaining muscle tone. In the narcoleptic brain, there are fewer orexin-producing projections, and a loss of as much as 90% of orexin produced in the lateral hypothalamic neurons are found in the CSF. Patients with narcolepsy have been found to have genetic variation on T-cell receptor alpha loci and an increase in tissue-type human leukocyte antigen, DR2, wherein some infections, typically airborne, stimulate the overproduction of HLA-DR2, and the orexin-producing neurons become targeted by the immune response. The result of this is a weaker inhibition of GABA production, leading to a feedback loop that further inhibits orexin release. There is a limit, however, to the sleep-promoting efficacy of GABA and its inhibitory effect on the lateral hypothalamus. As such, eventually the mild inhibition from the wake actives will overpower the effects of GABA, causing wakefulness. Note that this can happen any time, usually resulting in disrupted and chaotic sleep patterns even at night, with REM sleep being especially hindered. As such, narcolepsy is not a disease of sleep quantity, but REM quality. Over a given 24-hour period, a narcoleptic patient will sleep approximately 8 hours. The result is excessive daytime sleepiness and being more susceptible to eating disorders, depression, and other sleep disorders such as sleep paralysis.
Dr. Eagle, your patient is here.
Thank you, nurse. Hi, Katarina. Please take a seat just there. What brings you in today?
Well, I keep falling asleep and I'm worried I have narcolepsy. How do I know if I have it?
Well, initially doctors will suspect narcolepsy when patients report a series of symptoms, such as excessive daytime sleepiness and abnormal rapid eye movement sleep events, such as cataplexy, hallucinations, and sleep paralysis. Patients will then be referred to a sleep study centre, where a polysomnogram and multiple sleep latency tests can be performed.
Is there a way to manage it without drug treatment?
Yes, lifestyle changes can sometimes reduce the symptoms of narcolepsy, but the effectiveness of such changes does depend on how severe your case of narcolepsy is. For example, maintaining a regular sleep schedule, maintaining an optimal temperature in the bedroom, and avoiding caffeine and heavy meals near bedtime are all strategies you could employ. However, if your case of narcolepsy is more severe, you will require drug intervention.
In that case, what drug treatments are available?
The types of drugs prescribed will depend on whether you have type 1, which is EDS with cataplexy, or type 2, which is EDS without cataplexy. Historically, amphetamines were used in all cases of narcolepsy. However, these days, newer stimulants, such as modafinil, is the first-line treatment for EDS in narcolepsy, and sodium oxybate is the first-line treatment for cataplexy. Antidepressants are also used for type 2 narcolepsy as well. Modafinil is generally better tolerated due to it being pharmacologically different from amphetamines, and this also makes it at a lesser risk for potential abuse. However, it can have side effects like headache and nausea, and in rare cases can lead to erythema multiforme and Stevens-Johnson syndrome. It is classified as a monoamine transport reuptake inhibitor, which increases the extracellular concentrations of monoamines and also the hypothalamic histamine levels, rendering it a wakefulness-promoting agent. Recently, there has been evidence that it has similar properties to selective dopamine transport reuptake inhibitors. Sodium oxybate's mechanism of action is unknown, but it is a neurotransmitter affecting dopamine, serotonin, and endogenous opioids, and it may act via the GABA B or specific GHB receptors. This treatment type is used for type 1 narcolepsy, as it tries to promote increased REM sleep and in turn decreasing excessive daytime sleepiness and cataplexy.
Okay, so is there a cure for narcolepsy?
Unfortunately, there is no cure. All of the drugs and lifestyle changes we have discussed thus far are only for symptom control. However, new research is being undertaken all the time.
Thank you, Doctor.
Anytime, Kat.
In the words of famous rappers everywhere, yo mama's so narcoleptic, she can go from 0 to REM sleep in 5 minutes. Anyway, as a recap, narcolepsy with cataplexy is linked with the destruction of hypothalamic neurons responsible for the secretion of hypocretin orexin needed for arousal. This is most often linked to an allele connected to autoimmune dysfunction associated with T cells, showing a connection between autoimmune disorders, including diabetes mellitus type 1. It has been hypothesized that a cause of this narcolepsy is due to H1N1 vaccines mimicking a neurological autoantigen normally associated with the destruction of hypocretin orexin neurons. In other words, H1N1, we're breaking up with you, and it's not me, it's you.
There are two promising developments for future research. This involves L-tyrosine and the use of sodium oxybate. Dopamine abnormalities appear to be the primary cause of narcolepsy, so future treatments would likely involve the normalizing of dopamine levels in the brain. The precursor of dopamine is L-tyrosine, a non-essential amino acid. There is a link between brain tyrosine levels and dopamine, as increasing L-tyrosine increases dopamine. An optimum level of dopamine can be achieved by manipulating L-tyrosine levels in the body.
The first use of L-tyrosine in narcolepsy was performed in 2008. It was discovered that sleep disorders and depression is associated with low levels of L-tyrosine in the body. 23 narcoleptic patients have been successfully treated using L-tyrosine. Those who had no previous drug therapy appeared to have the best therapeutic response.
Gamma-hydroxylbutyrate, or GHB, has also shown promise and is useful in controlling cataplexy and improving night sleep. Due to its misuse in athletes, GHB has become heavily restricted before re-emerging in the past few years under the name sodium oxybate, the sodium salt of GHB. Sodium oxybate is effective by acting as a neurotransmitter via its own receptors and via the stimulation of GABA B receptors. Patients will often start to show improvement within a few days, but optimal response at any given dose may take as long as 8 to 12 weeks. Clinical trials indicate a number of adverse side effects, and it is not advisable to prescribe sodium oxybate to depressed hypersomniac patients.
Celebrate cat, we treated your disorder. Celebrate cat, yes we do. Celebrate cat, enjoy all your lectures. Celebrate cat, we are happy for you.